Hello, and welcome to the Cass Health Podcast, the show where we hope to connect our community with healthcare information that's relatable, understandable, and useful to your life, and where you get to know better the neighbors providing your care here. I'm your host, Carter Anderson, and in today's episode, we'll be talking about gastric sleeve surgery with Dr. William Rizk. Before we get started, two quick disclaimers. First, the comments in this podcast do not necessarily reflect the views of Cass Health. Second, the information in this podcast is not intended to be construed as personal medical advice. Always consult your primary care provider with questions and concerns regarding your health. Welcome. Thanks so much for taking some time to chat with us today, Dr. Rizk.
Thank you. Happy to be here.
Yeah, so we'll start with a couple rapid fire questions to kind of get to know you a little bit. So the first one is, where are you from?
Well, I was born and raised in Sioux City, Iowa, and left and went to college at the University of Iowa, and then went to med school at University of South Dakota, did residency in Des Moines, Iowa at Iowa Methodist Medical Center, did a little stint for some advanced laparoscopic training in Kansas City, and then after all was said and done, ended up back in Sioux City and practiced there for 25 years.
25 years in Sioux City, is that what you said?
Sioux City, okay. But I technically live in Dakota Dunes, which is in South Dakota, very, very close. I lived in Dakota Dunes, and my kids actually went to school in Iowa, in Sioux City. So we would live one place, and I took call in Iowa and lived in South Dakota, which sounds kind of unusual, but it really was only about a 12-minute drive.
Gotcha, and it all worked out okay. That's interesting. So, favorite sports team?
Ooh, good one. Iowa Hawkeyes.
The Hawkeyes all the way. There you go. I'm a Cyclone, but we won't talk about that. Okay.
Sorry about that.
Right? I was going to say.
My parents went there. But.
Oh, there you go. I was say, stepped out of their footsteps there and went to the University of Iowa.
Yeah.
Nice. Do you have any other ones? Any pro teams or anything
Chiefs.
Like that?
Yeah, we like the Chiefs, too.
There we go. That's a good team, too. If you're cooking, dinner to impress, what are we making?
Well, first of all, my wife, I have to be honest, does most of the cooking, but when I do bring it out, it's usually a beef tenderloin with a whole bunch of seasonings on the grill, and that's kind of my go-to for special guests.
There you go. Say, I'll be coming over. That sounds pretty darn good. Favorite holiday?
Thanksgiving. It always just feels like a series of Saturdays, interspaced with football and good food.
Yes, like you said, it's like, it's the third Saturday. Gosh, when it's actually
isn't
Saturday,
it Sunday
right?
yet? Yeah. No. Oh, it's another. Oh, gosh, it's actually Saturday.
Right.
Finally.
And you eat. It seems like a lot of the same food because you have the leftovers a couple days after that. So.
Exactly.
What's better, the book or the movie?
The book is always more detailed. Love a movie, but I'm going to go with the book.
I agree. Next or dream travel destination?
Always had a dream to go to the Greek islands. Hoping to make that come true. That would be awesome to have a little boat tour in the Greek islands.
Awesome. Is there a place that you've been like recently that you really enjoyed? Are you a traveler at all or not really?
No, definitely a traveler. Very recently, we were just up in Minnesota at Potato Lake. I'd never really been there. My sister had a big birthday, and she wanted all the family to go up there because we kind of grew up going to lakes in Minnesota, and we had an amazing time. Because I'm an Okoboji guy. We have a place at Okoboji, and we spent a lot of time there. And I love Okoboji, love everything about it. This is dramatically different. Way more laid back, very few boats. We do a lot of water sports. Be the only boat on the lake, no waves, just completely different. No restaurants on the lake. You just grill every night. Played horseshoes in the yard, campfires every night. So that's the most recent.
Say more of a, not bare bones, but like you said, less commercialized.
Yeah.
Because I've been to Okoboji a few times too.
Good way to put it.
Yeah, that's fun. That's awesome. Any pets at home?
Rest in peace. My dog Boots, 16 years.
Ooh.
She was a great dog and just kind of ran out of gas very recently, probably within the last 3 months.
Oh.
So right now we do not have a dog. We do not have a pet. All my kids have moved away, so we're going to hold off for now.
Right. And be able to not have be tied down by anything at home, right? Be able to kind of go wherever you please. There you
exactly.
Go. What was Boots?
Boots was half beagle and half border collie.
Oh.
So very active and smart little dog.
I was going to say intelligent and kind of knew what they were doing. That's funny.
Used to herd the kids when they were young.
I was going to say, right? That's say did she get the herding part of the border collie?
Absolutely.
That's funny. Any hobbies?
Yeah, very big golfer. Play a lot of golf. Traveler. Do some hiking. Do some water skiing. And just on our recent vacation, did some barefoot water skiing. That's something I've done all my life, and kind of got it out of retirement because we were at this amazing lake where they had no boats. So got the barefooting out.
With the barefooting, do you kind of need the water to be like pretty still, or does it go okay with it?
No, waves do not go well.
That's what I'm like. The waves would be.
You have to go pretty fast, and you have to have pretty calm water. And when you wipe out, you definitely face plant.
That's what I was going to say. I feel like there's only one way to go.
There's only one way to go, yeah, because your toes kind of hit the water. And so the videos are actually, my kids were videoing, and you see some just like pretty nice wet butts.
Can we pop some of that video in?
Oh,
you know
boy.
what I mean?
Oh, yeah. I have it. I don't think you want to see it.
We always like to hear from people about why they chose their career. So kind of what made you want to go into medicine and become a surgeon more specifically?
When I was in high school, one of our really good family friends was a surgeon. And I was always had an interest in medicine. And this was before it was really a thing. One day when I was probably 16, he said, why don't you just get off school for one afternoon and come shadow me? And I went in the operating room and I was watching him. And he was a general surgeon, which ultimately I ended up becoming. And I shadowed him, and none of my friends, anyone had ever heard of doing such a thing. And it just completely captivated me. And I walked out of there, and I said, this is what I'm going to do. And everyone said, oh, yeah, right. You don't have all this school. You don't have to take all these tests. And I said, I'm going to be a surgeon. And then I went through all my training, and you have to do all these different rotations and try every different field. And I tried to be open-minded about other areas of interest, but really everything, nothing could ever compare. So at the end of the day, I chose general surgery. And then ultimately, when I was looking for jobs, I truly didn't want to go home. I really looked all over. And then I got married and had kids, and then your perspective changes somewhat. And we decided for various reasons to move back to Sioux City. And I ultimately joined Dr. Carlton, the same guy who allowed me to shadow. And he kind of became my mentor, and he kind of welcomed me to the practice. And he would always see me when I was going through my schooling, go, when are you coming back? We're going to sign you up? When are you coming back? And I was like, yeah, sure, I'll see you then. Whatever. But it actually came to fruition. And so that's what kind of got me into general surgery, and that got me in.
That is awesome. So the very first person that was like, hey, you should come check this out, ended up being kind of your mentor once you got all that.
Yes, correct.
Stuff done. That is incredible. So I know here at Cass Health you do bariatric surgery. What kind of led you to that part of it? I know you said you started out with general surgery. I didn't know if there was
general surgery, as the term implies, it's a very broad subject, predominantly abdominal surgery, so colon and spleen and gallbladder and hernias and different cancers. And one of the things I did a partial fellowship in advanced laparoscopic. So we're going to talk about that, but laparoscopic surgery is also known as minimally invasive surgery. And so I really was attracted to complex, minimally invasive surgery. And so when bariatrics came out in the early 2000s, I started in 2002. That was widely considered the most complex laparoscopic surgery that was basically available. And so now they have full 2-year fellowships basically in this. But when I did it, there weren't fellowships. They did not exist in this field. So the way it worked in those days is you would go to a surgical mentor, and the companies like the equipment companies would set you up because they wanted you to use their equipment. So they'd want you to meet with these really amazing surgeons, and you'd go there for 3 or 4 days and you'd shadow them in their practice, and they'd basically teach you step by step how to do it. And so came back and started doing the original surgery that everybody did was gastric bypass surgery, which is different. We're not doing that surgery here at Cass Health. It is a very good surgery. It's definitely more technically challenging and slightly more risky. Over the past 20 years I've been doing weight loss surgery, that surgery has sort of faded in popularity. And probably 2010 to 2011 to 2012, the sleeve gastrectomy began to emerge. We started doing that in 2012. And recently, probably the last 6-7 years, globally, that is now the number one most popular bariatric surgery. Bariatric also means weight loss surgery. Sometimes that's a confusing term. Now that worldwide is the most performed operation.
Gastric sleeve is
the gastric sleeve.
The gold standard for that bariatric surgery.
I would not say that.
Okay.
So I would say there's no gold standard.
Okay.
There's no magic bullet. There's no perfect surgery. There are multiple surgeries. If you can Google or do anything, there's multiple surgeries that are done across the United States today. What I'm telling you is that the sleeve gastrectomy or the gastric sleeve is the most common, but every surgery available has pros and cons. So, and the sleeve surgery has pros and cons. So really what we like to do is to look at the patient and look at the available options for surgery and see what surgery fits the patient. Now, it just so happens that the sleeve fits almost everybody, and most of the patients like the surgery that's the safest, that still has really good results. So that happens to be the sleeve in most of the cases. But even when we see patients here at CAST, there will be patients that probably I will say, I'd love to do your surgery here in town, but the best option for you is something different, and you're going to have to go to Omaha or Des Moines to get that option. So you just can't fit everything into the same box or the same shoe. It's a great surgery, but it's probably good for almost everybody, but not everybody.
Right, and to kind of focus on patients now, what kind of is the positive impact that any gastric or bariatric surgery has on patients? Kind of like, what are the long-term benefits for those people that undergo a surgery like that?
Sure. The main reason that anyone undergoes bariatric surgery or weight loss surgery is to improve health, period. That's it. So if we look at medical conditions that are worsened or related to obesity, at last count, there was almost 200. So there are multiple medical problems. Common ones we've all heard about are diabetes, high blood pressure, high cholesterol, sleep apnea, heart disease, fatty liver. There are many more. Almost all conditions, I'm going to say all conditions are improved with bariatric surgery. A large percentage of medical problems can actually be resolved or completely cured. Now, a lot of it depends on what the nature and the chronicity of the disease are. If someone is a new diabetic that's maybe been on oral medication and no shot medication, they have a very, very high rate of completely resolving their diabetes, as opposed to someone that might have had diabetes for years and is on insulin and may have kidney or eye problems. Those people will definitely see improvement. But as far as completely, quote unquote, curing the disease, it's a much more difficult cure than someone. So it really depends on how severe the disease is and what it is. But the main reason, getting back to your question, that people would have bariatric surgery would be to improve health.
Let's start with obesity. How is that defined, and what does that kind of matter in terms of people's overall health?
Obesity is a condition, a chronic health condition, and the way we measure obesity is a number. That number is called BMI. When I started practice, we would just kind of measure people's heights and weights, and that really wasn't something we always calculated. But today, almost every doctor visit, for sure here at CAS, if you come to the doctor's office, a BMI will be calculated. So that's a number, and that number is a number that represents obesity. It's not just your weight, remember. It's a relationship of your height and your weight. And so what does that number mean? So what's considered normal, if someone's BMI is less than 25, that's considered normal. When we do bariatric surgery, we're not really shooting for a BMI number. We're really shooting for health parameters, not BMI parameters. But just to kind of educate you as to what the numbers just broadly mean. The next classification of BMI is what's considered overweight. And that's where a lot of people fall into, is BMI between 25 and 30. Where we get into the first class is obesity, is when it's over 30. And kind of when you kind of look at the textbooks, there's three classes of obesity, class 1, 2, and 3. And class 1 obesity is when a BMI of 30 to 35. Class 2 obesity is 35 to 40. And class 3 obesity is greater than 40. Now, the other term that nobody likes is morbid obesity. So that relates, quick question, a little sidebar. I was doing some research and I came across the Guinness Book of World Records for the highest BMI. Any ideas?
And you said like the highest one that is like over 40. I'm like 65 maybe, like for the highest ever.
Yes, the highest ever BMI is 186. So Guinness books obviously have big numbers. That gets us into who are candidates for surgery. So anybody whose BMI is greater than 35, and we always round up. So 34.5 would round to 35. Anyone whose BMI is 35 or greater is a candidate for surgery, irregardless of medical problems. That number can drop as low as 30 if the patient has one medical problem on a medication. So examples of that would be high blood pressure. You have to be on at least one pill. Chronic heartburn on some sort of medication. Sleep apnea, diabetes, fatty liver, and high cholesterol. So you just have to have one of those criteria. So if you have one of those criteria and your BMI is between 30 and 35, you are a candidate for surgery. And there's always the unusual area of being a candidate for surgery and then having your insurance pay for surgery. Now, the frustrating part of what we do is that all other medical conditions that we seem to encounter, if you have medical insurance, you go to the doctor and you can get it taken care of. With weight loss surgery, the majority of insurance products do cover weight loss surgery, but there are certainly some that do not. Now, one thing to know, Medicaid and Medicare do cover weight loss surgery, but there are some private insurances that do not. So that's something that during the evaluation process as a patient, you definitely need to know if your surgery is going to be paid for or not.
Right, absolutely. That's what I wasn't sure, like for insurance to cover it, if you had to have, like you said, one of those.
You definitely
multiple.
do.
That's what I didn't know if it was like just one that you had to have, if it was you had to have multiple.
So I'm giving you the bare bones criteria.
Okay.
Now, many patients we see might have a BMI of 45,
mm-hmm.
and they might have diabetes, high blood pressure, and sleep apnea. So you can have more, but I'm giving you the least amount of criteria that for insurance to cover.
What about using GLP-1s like Ozempic or focusing on nutrition and activity? Is that something that patients could do?
Those new medications, Ozempic and Mounjaro, those are the two big ones. They're actually great weapons in our arsenal. And I always kind of think of fighting obesity as really we have a toolbox full of tools. We have multiple surgeries available. We had older drugs. These are by far the best medications available. We have diet, we have exercise, and we have counseling. We have kind of all these different things that offer benefit to the patient. I kind of like to think about each being a tool. And the thing about these is that we can only expect a pretty small, I think with Ozempic, for me, if someone needs to lose 20 to maybe max 40 and ultimate max 50, that medication is okay. It's actually probably a great place to start. It's also great for people that have had weight loss surgery. And again, I've been doing this for 20 years, maybe 15 years ago, and they maybe gained 20 and they want to get that 20 off. It's a great medication for that. But the problem is if someone has a very high BMI, say their BMI is 40, and they want to lose 100 pounds or 125 or 150, to really expect these medications to provide that degree, that tool isn't good for that job. In addition, we know there's an expense to these, which is okay if we think it's going to work long term. I'm okay with that expense. And also, probably you're going to need to be on it for a long period of time, which again, if we're going to get you to a healthy weight and you can stay there reasonably, I think it's okay. But I think to try to lose a really dramatic amount of weight on those medications, it's probably a stretch for those. And I think probably not a good idea. And the long-term success rate is probably not going to be great.
It's like trying to cut the yard with a pair of nail clippers, right? It's
yeah, I mean, you can do it. I mean,
it's just
not the right tool for the job. Well put, exactly.
To kind of go into the gastric sleeve surgery then, what is gastric sleeve surgery?
Great question. So the key component to gastric sleeve surgery is it makes your stomach smaller. So if we think about how do we digest food or digestive anatomy? So when we eat food, we chew it up in our mouths and it goes down our food tube, which is called the esophagus. And the process of digestion begins in the stomach. So your stomach kind of is the storage container for food. And then the food then travels into the small intestine and then into the large intestine, which is also called the colon, and then out. So the sleeve surgery focuses only on the stomach. Now, some of the other surgeries that we discussed earlier, like the gastric bypass, focus on the stomach and the small intestine. So the stomach, if you look at the size of the stomach and relate it to a common item, it's about the size of a football. So the whole concept of the surgery is reducing the size of the stomach by using our surgical tools, and we reduce it to the size of a small banana. So effectively, we're going to remove about 80% of the stomach. And by doing that, it really does two things. I mean, the most obvious is it reduces less real estate. There's less real estate for you to hold. You're going to eat less. Your stomach then will hold less. It will send signals to your brain that tells you you're satisfied, and you feel less hunger. The other part that a lot of people don't understand is in the part of the stomach that we remove, in the 80% that comes out, there's a little hormone in there called ghrelin. And that hormone, AKA also known as the hunger hormone. And there's really good data that shows that because of what a hormone is a substance that's produced somewhere, travels through the bloodstream and acts somewhere else. So the ghrelin is produced in the stomach, travels to our brain, and stimulates our brain to eat. Interestingly, people can never remember the term ghrelin, so we call it gremlin.
Gremlin.
It's like a little gremlin. The gremlin goes through it. It's like picking on your brain, telling you to eat all the time. Mm-hmm. So what the surgery does, when we remove that part of the stomach, gives you a smaller stomach, and the desire to be hungry is amazingly lower. So it's really kind of a two-prong. Yes, it's a physical entity that your stomach is smaller, and there's a whole bunch of other hormones at work. This is just the big named one, but there's a whole bunch of data that shows there's a whole bunch of other hormones, leptin and PYY, all it's way beyond the scope of this discussion that people don't even need to know. But the bottom line is our bodies are very complicated, and this does change some of our body chemistry. At the end of the day, what it does is that we eat less food, and by eating less food, we take in less calories, and that we lose weight. We do not suck out fat. That's a very common misconception. It takes time to lose weight. Usually we say it takes about a year to lose all the weight. Some people lose it all in 9 months, but that's still pretty fast. For someone to lose 175 pounds or 150 pounds or 100 pounds in 9 months to a year, that's still pretty rapid weight loss. And another thing is that losing weight quickly is not dangerous. Sometimes friends and family members are worried about their loved one. First of all, is the surgery dangerous? No, this is a very safe surgery. Number two, what we're going to do is teach you how to eat healthy and what to do to avoid the pitfalls of losing weight quickly. So you have to stay hydrated. With our dietitian's help, we're going to teach you what particular foods, since your stomach is small, it won't hold a lot. So what you eat is really important. And finally, taking vitamins becomes very important. Don't want patients to learn by trial and error. We can help prevent a lot of problems. So as a part of our educational program, we can help teach patients before, and that means they can still lose weight quickly, but do it in a safe and very healthy manner.
What are outcomes for patients after the gastric sleeve surgery? What can someone expect after they go through that football to banana transition of their stomach?
So as patients are recovering, we don't just go back to regular food. As our little stomachs are healing, we do have to do a slightly modified diet for a 4 to 6 week time period. And when that happens, when the patients are eating not necessarily solid food, there's a progression. We go from thicker liquids to pureed foods to softer foods. The weight really comes off very quickly. Half a pound to a pound a day the first 30 days is very, very common. So people can be 30 days out, and some people are 30 plus pounds down. Now, again, not everybody. It really depends on where someone starts and how closely they're following things. But again, patients are going to see very quick results. Now, again, there's data to show, like people always wonder, what am I going to, at the end of the day and at the end of a year, how much am I going to lose? So what is a very good predictor for sleeve gastrectomies? We usually say it's about 50 to 70% of the excess weight. So say someone's 100 pounds overweight, that's used to be one of the criteria they use. So say I'm 100 pounds overweight. If someone lost 50 to 70% of that, so 50 to 70 pounds would be the expected. Now that's average. So sometimes people do better than average. Sometimes people do worse than average. So when people come for a consultation, we always kind of plug their height and weight in and kind of do the math and give them an expectation of where we think the average person would end up. And I always say, this is average, so I'd love it if you'd be an overachiever. Right. Prove me wrong. I'm not guaranteeing you're going to end here. We're just trying to get you in the ballpark of where we think.
Right. On average, a person with your circumstances would lose this amount of weight or whatever. You kind of get to ballpark it that way with the BMI.
Now, the one kind of disclaimer is that not all weight loss surgeries are perfect. What I will say is that in the beginning, almost everybody loses weight within the first 6 months. As a matter of fact, even in the surgical literature, they call it the honeymoon period. It's really hard to mess that up. And patients are always very motivated. Almost 100% of patients always start out really well. However, no surgery is perfect. And what it really is, surgery, like all the things we discussed earlier, are a tool. And the patients who use the tool to change their lifestyle, that is really the key ingredient to making this last. And this tool helps you to change your lifestyle because it does help you certainly eat less. Because when you have a small stomach, you eat a small amount of food, your body feels satisfied and full. And that's completely different than a diet. And I always say to patients, this is not a diet, nothing like a diet. It doesn't feel like a diet. Your plate portion size may look like a diet, but your brain won't interpret it as a diet. And so that part makes it okay, but then living with it. So basically, no surgery is 100% effective. And so the numbers we usually quote for the sleeve gastrectomy, it's about 80% long-term effective. And so what does that mean is that 1 out of every 5 people that have the surgery long-term may end up gaining some weight back. And almost universally, the bad habit that tends to creep into patients' lives would be that of eating multiple small meals a day, otherwise known as grazing. And there are other diets, I've heard about them extensively, where patients are taught every 2-3 hours, we're going to give you a little snack, a little prepackaged plan, and you're going to take this at work, and you're going to eat your little snack multiple times a day. This is different. And part of our educational program is we'll teach you how to eat. Ultimately, we're going to have you eat about every 6 hours. So at the end of the day, 3 meals a day is going to be what your life would be like after surgery. Occasionally, there'll be some snacks, but for the most part, we want you to think 3 meals a day, not lots of little snacks. And if people do that, and most of the time, patients will not be hungry between meals. For the reasons we talked about earlier, patients are not hungry, and they're able to maintain their weight loss for the long term.
I know there are a few misconceptions out there, like will patients like banana-sized stomachs ever stretch back out?
Oh gosh, that's the thing I hear every day. That thing, will the stomach stretch out? Number one question. People always say, oh gosh, I had a family member, they were up in Ames and they had this surgery and gosh, they stretched their stomach, they ate through all the staples. Next thing you know, they gained all their weight back. The reality of it is no surgery is perfect and patients are able to gain back weight if they develop, like I said, the majority of it's one bad habit called grazing. So one of our evaluations, if someone does gain back weight, is that we do a test called an upper GI to measure the size of the stomach. And almost universally, the little stomach that we had created stays small even years and years, even 20 years after. And so the little stomach is still the little stomach. Now, it gets a slight bit bigger over time, but the little banana will never be as big as the football again. And so ultimately, it comes down to behavioral changes. And what happens is people kind of forget about the tool and they let kind of that grazing kind of sneak into their life. A lot of times it's eating, but sometimes grazing can also be high-calorie liquids, like too much alcohol or the fancy coffees in the morning. The espressos have lots of calories. And we're not saying you can't have that, but it's when people do a lot of that can cause problems.
What is the process kind of like leading up to surgery as far as education goes for patients? Can you tell us a little bit more about the education that patients will get?
So as I said, I was a general surgeon, and I do this surgery, but I do many other abdominal surgeries. And kind of the interesting thing is say someone comes for a gallbladder surgery, which I don't do here, by the way, but they would come and see me in the clinic, and they may, because they're having pain, I might do their surgery tomorrow. It can happen that fast. So one expectation for patients that we need to have is patience, because this process is complicated. We're doing a physical surgery to reduce the size of your stomach. For sure, we could do that tomorrow. However, living with a small stomach successfully requires education and planning and preparation. Because while your stomach heals, you can eat the wrong food that might mess it up. And knowing how to eat, what to eat, how would anybody know that? There's a learning curve and we have to teach you. So we have what's called a multidisciplinary team approach here at Cass Health. And so when you come for your surgical consultation, of course you meet with me, that I'm the first person you talk to, but you'll also meet our team. We have a bariatric dietitian, a bariatric coordinator, and bariatric nurses that will work with you and help educate the patient before surgery. So usually there are multiple meetings that occur between the original surgical consultation and surgery. And that does take time. Whereas I mentioned the gallbladder, I see one day, do the next. what I always tell bariatrics is the quickest someone can get surgery at a minimum is 2 months. And I know patients, once they decide they want to do this, they're very excited, and I respect that, and I appreciate that. But on the other hand, to help improve success, a multidisciplinary team definitely does that. So going through the process is definitely mandatory. And we do it in person. We don't do Zoom or Skype or anything at this point. And it really does help improve the patient process and the patient success. So patience is key. Time moves quickly. And before the patients know it, it'll be time for surgery.
There you go. Like you said, that kind of 2-month process. Yeah, it seems like a long time, but it's like we're talking about the rest of your life here, right? Like a lifelong change in process of the ways that you've been doing things. So.
And that's 2 months minimum. So sometimes people, because say they're 2 months, they get through their approval, then they might have some work obligations. So it could be 3 months, it could be 4, it could be longer, but that's the least.
To kind of have some lifelong success with this, using this tool kind of long term, what is important for patients to know?
I think that one of the big take-home points is the understanding this is not a magic bullet. They have to understand that they have to change lifestyle. One example, say someone has multiple Mountain Dew. That's something I see very, very commonly, regular Mountain Dew or regular pop. Patients have to understand they just aren't going to get surgery if they aren't willing to. They're going to have to give up some of the things that are clearly bad. So this is a tool. It will definitely help you eat a smaller meal, but it's not, I'm doing surgery on your tummy. I'm not doing it on your brain. So there's still going to be, you're still going to have to get up and go for walks. You're still going to have to come to the preoperative classes. You're still going to have to get up and do your daily obligations. And people say sometimes it's the easy way out. It's kind of frustrating because there's a lot that goes in. As all the things we mentioned, it takes months to have surgery. There's multiple classes you have to attend. The easy part is that it's easier to eat less. But there's a lot of other things that do go into it. Taking vitamins every day, making sure to come to your appointments, doing the obligations that you need to do to be a good patient. But if you do all that, and if you kind of listen to the team that we have, the results are amazing. Some of the most unbelievable patients. It's so rewarding as a physician to see patients who you change their lives, and some people that were walking with a cane or very much in pain walking in. A year later, they're basically skipping in. They show me their list. They're off 15 meds. They're down 110 pounds. I've had people say they ran 10Ks. They went water skiing. They went hiking, just all these activities that they could never do before. It just opens up a whole new world, and it's really rewarding as a physician just to see the success story after success story. And it's almost everybody. And people say, oh gosh, I've just never been able to lose weight. I've heard that a million times. I know that feels like, as a patient, feels like you're never successful. This is just a whole different world. And this is something to be able to deliver success when all the other things have failed. That's when this will work.
And is that super satisfying and gratifying, from a physician perspective?
That was one of the biggest surprises. I kind of went into this thinking, oh gosh, it's kind of a video game thing. It's technically, I like the game, video games. I like working with my hands. I thought it'd be cool. It blew me away. I didn't even realize it for probably a year, that how rewarding it would turn out to be, seeing patients actually come up and hug you and just show how happy they were to have grabbed back life when they thought it was gone.
This process is super intricate and I can do it. And then you kind of get to the end of that first year, that first batch of bariatric patients, and then you kind of get that other layer of satisfaction to give people their life back. It's pretty awesome. When people come in for that surgery, what can they expect, like as far as incisions, how long surgery will take, kind of stuff like that, just kind of the different specifics of the gastric sleeve surgery?
Sure. So the key component to the way we do this, the technique of the surgery is called laparoscopic sleeve gastrectomy. So the laparoscopic technique is not just for this surgery. It's for gallbladder surgery. It's for ovary surgery. Laparoscopic means using multiple small incisions instead of one big incision. And so with this particular surgery, we use 5 small incisions. They're all very small, the size of my pinky nail. We introduce our instruments through those little incisions. Our instruments are connected to a video camera so that we're videoing the inside of your body and projecting your insides up onto TV screens. So while we're working on you, we're actually looking up at the TV monitors and able to do our job. The surgery usually takes about 45 minutes to do the surgery. And currently, the majority of patients at Cass Health will go home the very same day. So this will be a same-day procedure. So we're excited about that. It is done under general anesthesia, so the patients will be fully asleep Patients don't remember anything. They won't feel anything. The little incisions are closed with skin glue. Patients are able to go up and down stairs immediately. They're able to shower immediately. Usually we say a tub bath or a hot tub within a week, as long as everything's healing okay. Driving in just a day or two, as long as they're off their pain pill. Back to work is highly variable depending on what you do for a job, in as little as 3 or 4 days to as much as 6 weeks. But surprisingly, patients who have a desk job and if they have some flexibility or they work at home, a surprising number of people are back at work. If we do our surgery on Thursday, they're back at work on Monday.
That's crazy, the turnaround time of that. That's
and
awesome.
So the key thing I always remind patients is if they do want to go back to work early, they're not going to be 100%. But on the other hand, they're not going to hurt anything. So I love patients to be active. It really, the more someone walks after surgery, better for them.
When you pare the stomach down from the size of a football to the banana, what's that process like? Like those staples and all that stuff, like, or do you glue, like, how does that work?
No, so what we have a special, again, like I said, there's these laparoscopic instruments. They're very amazing, very technologically advanced. And the most key instrument that we have for the surgery is called a laparoscopic stapling device. Kind of a cool little thing. It has a battery pack, so it's powered. What it does is it lays down 6 rows of staples. So it staples on the banana, it staples on the part we're going to get rid of, and then it divides in the middle. So we end up applying that stapler usually 5 times to the stomach, and then everything is sealed off so that nothing spills. We don't want to spill gastric content. None of that ever happens. And then the part of the stomach we're not going to use, we pull it out through the belly button. And then the little metal staples that stay in the patient are made of titanium. They don't rust. They do not dissolve or go away. They do not set off airport metal detectors. You can have an MRI after having this. A lot of people wonder that, so that's okay to do. So even if a patient had an X-ray 10 years later, they're very small, but a skilled radiologist, if they looked very carefully, could see the little staples. People sometimes worry, my stomach was stapled. Is that a problem? The little staples do not cause any problems. We've been using these staplers for more than 30 years. Not a problem.
That's awesome. It sounds like it almost kind of creates 2 separate
It kind of does.
Ziploc bags, like, you know what I mean? Like, it like seals them both shut and
It's a
pulls,
very good
pulls
analogy.
the one out.
Very
There we
good
go.
analogy.
So, cool.
And if you ever want to see, you can just put in sleeve gastrectomy video on YouTube.
Okay.
You can see it for yourself.
See all of it.
And amazingly, you'll see no blood.
That's what I was like.
No blood.
Like
You'll see no blood. I mean, that's a problem if you do.
Right?
But usually
you
you
got a
don't.
bigger issue if you see the blood.
Usually
There
you
we
don't.
go. Okay. Thanks so much for taking some time to talk with us today and teach us all about gastric sleeve surgery. It's been awesome.
Yeah, well, thanks for having me, Carter.
Yeah, you betcha.